Good evening, everyone. My name is Claire, and I'm a member of the team at Dollar Orthotics based in Australia. Tonight, we will present the first in a series of webinars designed to help build orthotic confidence in clinical practice. Tonight, we will focus on the selection and practical use of prefabricated orthotics. Due to the time difference between Australia and the UK, we have pre-recorded this presentation earlier today. This first webinar will look at the selection of prefabricated orthotics versus custom orthotics. Look at the type of prefabricated orthotics available and how they can be used in clinical practice. Look at options for different footwear styles, biomechanics and pathologies. We will look at examples of the most common frontal plane and sagittal plane orthotic modifications used on a thermoplastic blank and how to DIY them in clinic yourself. We will also look at examples of OTC orthotic options with the same design features, giving you options for your clinic. The resources available in this presentation are available on our YouTube channel, and our partners at Canterbury Healthcare will make sure you have access to education and training resources and forward any questions from today's presentation. In this presentation, the term orthotic will be used to describe a foot orthotic or medical shoe insert, not other forms of orthotics including AFOs, prosthetics, or braces. According to the APOD-C Guidelines for Orthotic Therapy, published in 1998, orthotic therapy is the use of an appliance or apparatus to support, align, prevent or correct deformity, or to modify the position or motion, change timing of force, and improve the function of movable parts of the body. Key points from this include the concepts of what you can use an orthotic to achieve for the individual patient. The ability to use an orthotic as part of your management plan to either treat an existing presentation or prevent pathology through the identification and modification of risk factors. The terms align versus support introduces the concept of two different types of orthotic approach based on what the aim of their prescription is. This refers to the concept of a functional orthotic, one that looks to promote change when capable, versus a more accommodative orthotic or supportive design, used to hold the foot or part of the foot that is poorly functioning. A common example of these two different approaches is functional hallux limitus versus hallux rigidus. In hallux rigidus, there is a significant restriction of the first MPJ range of motion, both on non-weight-bearing assessment and the same on weight-bearing assessment. This can be from a variety of causes, including surgery, the long-term effects of foot mechanics and loading, or a disease process, including osteoarthritis or rheumatoid arthritis. The patient will present with symptoms including pain when the joint attempts to function, so pain on weight bearing, pain on gait. There will be significant bony changes as seen based on Wolff's law. The aim of your orthotic in this case would be to support the MPJ or restrict motion. Orthotic prescription variables selected would have an accommodative aim for the first MPJ to restrict movement. An example variable would be a Morton's extension made from a material like polypropylene, carbon, or Dollar-Tech sheet. This could be combined with footwear modifications and promote a compensatory change in gait pattern while restricting the painful first MPJ motion. There are many other presentations that may lead you as a clinician to need to accommodate part of the foot. They may include advanced osteoarthritis, advanced rheumatoid or other seronegative arthropathies, complex regional pain syndrome or RSDS, acute gout, post-surgical fixation, spasticity or perineal spastic flat foot, motor neurone disease or disease process including MS or CP, or advanced diabetes in terms of the Charcot foot. This is one of the most common and controversial pictures used in the promotion or explanation of orthotic therapy. The picture is used to illustrate a frontal plane alignment change and is often linked to the root model of normalcy. However, we know that an orthotic doesn't just affect alignment. In fact, sometimes it doesn't change alignment at all, but still has a positive clinical effect on the patient. Research has shown inconsistent alignment changes for the same orthotic design, illustrating very individual or patient-specific effects. So why do we keep using this picture? What I take from this picture is the concept of change, or functional change. The aim of an orthotic can be to change function. This change in function may be position or alignment, but it also may be timing, force, pressure, load, or tissue stress. So can we actually change the attribute that you want to change? Is the foot flexible? Is it mobile? Is there range of motion at the joints? So let's agree that orthotics don't just aim to change alignment. So back to our functional example. In this case, we will look at functional hallux limitus. In functional hallux limitus, the first MPJ range of motion non-weight bearing is normal. However, in function, there are signs of impaired windlass or propulsion or avoidance of high gear. In the Jaques test, there may be a decrease in range of motion, an increase in force required to activate the windlass mechanism, or a delay in the windlass mechanism. Causes of this may include general foot mechanics and posture. Symptoms may include pain during function, tissue changes of both Wolff's law and Davis's law, and gait changes. During Jaques test, assess the range of motion available at the first MPJ compared to non-weight bearing, the amount of force required to initiate the windlass mechanism. Does the windlass mechanism initiate immediately, or is there a delay? The Jaques test is a weight-bearing or functional assessment of the windlass mechanism, which is required in the propulsion phase of gait as the heel raises off the ground. As the first MPJ dorsiflexes, the windlass mechanism should activate and the arch seen to raise. This should occur immediately, with little or no delay, and with as little force as possible for optimal function. Weight-bearing assessment. Assessment by dorsiflexion of the first MPJ during upright stance at 10 to 15 degrees ankle dorsiflexion. Key points to identify in the assessment: the dorsiflexion range available at the first MPJ and the positive activation of the windlass mechanism by raising of the arch. The relative amount of force required to dorsiflex the first MPJ as seen by windlass activation, and any delay in the activation of the windlass mechanism with first MPJ dorsiflexion. Management of any of these factors with treatment-directed testing or orthotic design features should aim to improve the windlass function, reduce the delay, reduce the force required, and improve activation. Features that aid in first ray plantar flexion, including inverting the rear foot, reverse Morton's extension, or forefoot valgus extensions, can be beneficial. Orthotic prescription variables selected would have the functional aims to improve the first MPJ function during gait. An example variable would be a reverse Morton's extension made from a material like Poron or EVA. This would aim to improve the first MPJ function, reduce the force required, or reduce any delay in the windlass activation. So getting back to our APOD-C guidelines for orthotic therapy, because we wouldn't want to forget what we are trying to achieve for our patients. An orthotic can be used to influence biomechanical alignment, or in this case, make functional change, to correct or accommodate a deformity, to relieve foot or lower limb pain and symptoms, or to reduce the tissue stress, and to protect or support an injury, assist in rehabilitation, increase mobility, and increase independence. Never forget what you are trying to achieve for your patient. Today's presentation will concentrate on prefabricated orthotics, but how do they differ from custom? A custom orthotic is made from a cast or scan of the patient. The cast or scan can be taken in a position which will influence the outcome of the orthotic and should be based on the patient characteristics. This is where the concepts of non-weight bearing, semi-weight bearing, weight bearing, subtalar joint neutral, as it lies, and mass positions all come from. The orthotic is manufactured to a customized prescription, either traditionally or via CAD-CAM.